Okay, now we're going to discuss the second part of neurology. So let's continue with degeneration of the disc, and that includes spondylolysis, spondylolisthesis, spinal stenosis, and also sciatic pain, and also herniated intervertebral disc. So let's talk about spondylosis. This is just no more than degeneration of the bones in the neck, if it refers to cervical, or depending on the location, it could be thoracic as well or lumbar. And the disc between them, when pressure is applied, it will compress the spinal cord at any level. So again, it's a degeneration process of the vertebral column at any level. Most common location is cervical, and is associated with soft tissue, and also has genetic component. The osteoarthritis is the most common cause. The first symptom that the patient is going to feel is often unsteady, jerky walk, and pain and loss of flexibility in the neck. Usually affects middle-aged and older people, and it is the most common cause of spinal cord dysfunction among people older than 55. As people age, osteoarthritis becomes more common, so it causes vertebra in the neck or any level to degenerate. When bone is in the vertebra, attempts to repair itself, it overgrows, producing outgrowth of bone, which are called spurs. SPURS, and also narrowing of the spinal canal, and that is spinal stenosis. And remember, that's where runs the spine and spinal cord. So the disc between the vertebra also degenerate, decreasing cushioning, and otherwise losing the protective factor of the vertebra against the spinal cord. As a result, the spinal cord may be compressed, causing dysfunction. Um, so some people are born with a narrow spinal canal, so that's why spondylolysis could be genetic. Um, Symptoms again, change in walking, leg movement, could become jerky, unsteady, sensation below the neck may be decreased. The neck may be painful and also become less flexible. Reflexes in the leg typically become exaggerated. When the patients would cough, sneeze, or will have any movement that increases pressure at the level of the spine, the symptoms will exacerbate. If severe, compression may impair bladder and bowel function as well. If spinal nerve roots are also compressed, the neck is usually painful, and the pain often radiates to the head, to the shoulder, and also to the arms. The muscles in one or both arms may become weak. Diagnosis is mainly through MRI of the spine, um, and treatment most likely related to anti-inflammatory, so non-steroidal anti-inflammatory drugs, sometimes surgery, and for muscle spasm, a muscle relaxant. Spondylolisthesis is another condition that's where vertebra slides forward in relation to the vertebra below. So again, it's a dislocation or subluxation, and it's usually due to trauma. Can result from a major trauma, most likely from high-speed deceleration injury in a motor vehicle accident. However, these disorders can occur with minimal or unrecognized or no trauma at all. If it is related to the cervical spine subluxation, patients will have numbness, and pain in the cervical spine with radiation as well to the head and to the shoulders. It could be associated with neck pain, occipital headache, or um, as I said, occasionally numbness in the area distal to the lesion. There's different stages of spondylolisthesis from stage 1 to stage 5 that basically there is um, a slide of the vertebra at about 75 to 100% um, subluxation. Now, spinal stenosis is another condition that's basically the narrowing of the spinal canal that puts pressure on the cord or sciatic nerve before their exit from the foramina. That causes positional back pain, symptoms of neck root compression, and also lower extremity pain during walking and weight bearing. It could be congenital or acquired. It may involve cervical or lumbar spine. It's a very common cause of sciatic pain in the middle-aged or elderly patient. And as previously stated, for almost all these conditions, the most common cause will be osteoarthritis. Um, it could also be related to spondylolysis or spondylolisthesis with compression of the cauda equina. Symptoms: pain occur in the buttocks, thighs, or calves during walking, running, climbing stairs, or even standing. The patient is not relieved by standing still, but by flexing the back or by sitting, although the paresthesias can continue. Walking up hills is less painful than walking down because the back is slightly flexed. Patients may have pain, paresthesias, weakness, and diminished reflexes in the affected nerve root distribution. Rarely, patients can also have cauda equina compression syndrome with loss of bowel or sphincter control. Um, Diagnosis is again by MRI, and treatment is bed rest, brief, to avoid thrombotic episodes in the legs, analgesics. Also, you could give medications to relieve neuropathic pain, and the most essential treatment would be surgery for severe cases. Now let's talk about herniated disc. This we already discussed briefly, which is degeneration of the disc. That could be idiopathic, biomechanical, or by compression. And patients again would have pain in the back and the sacroiliac joint, medial aspect of the buttocks and upper thigh, and a radicular pain that exacerbates with movement and straining. Herniated disc or herniated nucleus pulposus is no more than the prolapse of the intervertebral disc through a tear. The tear causes pain when the disc impinges and the close by nerve roots with paresthesias and weakness in the distribution of the affected root. Diagnosis is usually again by MRI or CT, and the treatment in mild cases will be analgesics and anti-inflammatories. Bed rest is rarely indicated in these patients with herniated disc, and patients with progressive or severe neurological deficit or intractable pain or sphincter dysfunction may require immediate or elective surgery, such as discectomy or laminectomy. So now let's talk about back pain. The risk factors again are occupation, exposure to vibration, uh, heavy lifting, obesity. Patients due to this could have the herniated nucleus pulposus, that basically the manifestations are the pain between the lower rib cages, gluteal muscles, and radiates to the thigh. This was already discussed. Uh, Basically, when the patients have sciatic pain along the sciatic nerve distribution, usually results from compression of the nerve roots in the lower back. Common causes include this intervertebral disc herniation, or osteophytes from osteoporosis, or osteoarthritis, narrowing of the spinal canal from spinal stenosis, and the symptoms we already discussed, pain radiating to the buttocks down to the leg. So this nucleus pulposus tends to compress the nerve root and compromise vascular supply, and also causes inflammatory like changes. Um, and the treatment is basically by anti-inflammatories, bed rest, epidural injections, ac- um, acupuncture, massage, or exercise, etc. Now let's talk about cerebrovascular disorders or stroke. Um, the majority of the strokes are is a group of disorders involving sudden focal interruption of the cerebral blood flow that causes neurological deficit. The majority of strokes, 80%, are um, ischemic, typically result from thrombosis or embolism, or 20% belong to hemorrhagic stroke. And that results from vascular rupture of either a subarachnoid bleed or intracerebral bleed. It could also be from an AV malformation or an aneurysm. Patients with transient stroke symptoms typically lasting less than an hour without evidence of acute cerebral infarction, that will be the TIA. Um, Diagnosis is based on diffusion MRI. In the United States, stroke is the fourth most common cause of death and the most common cause of neurological disability in adults. Even though your book says the third leading cause, the statistics from the neurological journal says the fourth most common cause. Can range from minimal to death, and the major risk factor for this will be always hypertension. Now let's talk about the different types of stroke, and that would be number one, TIA. Um, Transient ischemic attack is no more than focal brain ischemia that causes sudden but transient neurological deficit and is not associated with permanent brain infarction. Um, it's similar to ischemic stroke, except that symptoms usually last less than an hour, uh, or in some other books, says less than 24 hours. Most TIAs last actually less than 5 minutes. Infarction is very unlikely if deficit resolves within 1 hour. As shown by diffusion MRI or any other studies, that deficits that resolve spontaneously within 1 to 24 hours are often associated by infarction, and there's a discrepancy if to still call it a TIA or not. Is TIA actually the most common among the middle age and elderly adult neurological problems? Etiology, first, number one is hypertension, but second is dyslipidemia. Next, cigarette smoking, alcoholism, diabetes, obesity, sedentarism, stress, heart disorders as well, such as AFib, or prior MI, or prior infective endocarditis. Could be associated with certain drugs such as cocaine or amphetamine that increases vasoconstriction and hypertension. Patients that have hypercoagulability, patients that have any type of hereditary vasculitis, um, Male is a greater risk, older age, patients that have had prior stroke or patients that have family history of stroke. The majority of these patients have a transient mononocular blindness, which is called amaurosis fugax, which usually lasts less than 5 minutes, but may occur when an ophthalmic artery is affected. Symptoms could also begin suddenly, usually last 2 to 30 minutes, then resolve completely. Sometimes it could be associated with a headache, with dizziness, with hemiparesis that resolves spontaneously. You have to go through the same workup, um, even though patients sometimes get to the ER without symptom. You have to go through the same protocol with CT scan of the brain without contrast first to rule out any type of hemorrhagic event, even though the most common is ischemic. Um, Evaluation include also carotid stenosis, so carotid Doppler, EKG to know the baseline rhythm because atrial fibrillation is one of the most common sources of emboli event. Um, Echocardiogram, troponins, um, treatment basically is aimed to prevent other strokes or TIA events, antiplatelet drugs and statins. If the patient has carotid stenosis, they can go through carotid endarterectomy or angioplasty plus stent. Um, Anticoagulation is indicated if cardiac sources of emboli, such as AFib, is diagnosed. So now, ischemic stroke, which is the thrombotic, is basically due to an arterial occlusion that is caused by thrombi, uh, most likely related to the arteries that supply the brain or intracranial vessels, and very common associated with arteriosclerosis or any other type of inflammatory process. Is a sudden neurological deficit that results from focal cerebral ischemia associated with permanent brain infarction. Most common causes are from atherosclerosis, cerebral embolism, non-thrombotic occlusion of cerebral arteries, such as a lacunar infarction, proximal arteriostenosis with hypotension that decreases cerebral blood flow. Um, in addition, all the risk factors that were already mentioned for TIA are exactly the same. Um, Basically, what happens in the pathophysiology is that is an arteriothrombotic occlusion in the large arteries. Um, Atheromas tend to ulcerate and predispose to thrombi, and this impedes blood flow or creates a turbulent blood flow, particularly in the carotid bifurcation. Partial or complete thrombotic occlusion occurs most often at the level of the middle cerebral artery and also its branches. Also, the basilar artery could be affected, which is a branch of the internal carotid artery. Uh, Less common strokes are associated with chronic meningitis or any type of vasculitis, syphilis, hypercoagulability disorder, hyperhomocystinemia, patients that have any other type of hyperviscosity, such as polycythemia, thrombocytosis, um, AFib. Remember, patients that also have valvulopathy, such as mitral stenosis, any type of vegetation, any type of prosthetic valves could create this. The symptoms, depending on the part of the brain that is affected, the patterns of neurological deficit often suggest the affected artery. Um, Deficit may become maximal within several minutes of onset. Less often, deficit evolve usually over 24 to 48 hours. Patients tend to most of the time this thrombi dislodgement tend to occur during the night, um, and sometimes is first noticed upon awakening. All the symptoms from hemiparesis, motor, hemianesthesia, ataxia. Patients could have dysarthria, aphasia, seizures, and deterioration during the first 48 to 72 hours after onset of symptoms. Um, could occur up to the point of impaired consciousness. Diagnosis, again, is the CT of the brain without contrast first to be able to show where exactly is the location. And the treatment is based on antihypertensive therapy, antiplatelets, thrombolysis if the patient is hemodynamic unstable, and during the window of presentation to the ER. Um, Otherwise, anticoagulation and long-term control of risk factors that we'll discuss in pharmacology. Versus embolic ischemic stroke is basically fragments of thrombi that have been dislodged and produce an infarct secondarily in the brain. So again, the clinical manifestations is unless it's in the cerebellum, when it happens in the cerebrum, causes edema, compression of the capillaries, contralateral weakness in the arms, legs, or face, uh, possible motor disturbance, speech, depending on the location. If it's frontal, will be Broca. If it's temporal, will be Wernicke. Dysphagia could also be present. The difference between cerebral infarction and lacunar infarct is no more than infarction is basically an area of the brain that loses blood supply and become ischemic, and it could be due to ischemic versus thrombotic. If it's white, it's called ischemic. If it's red, it's called hemorrhagic. Um, versus lacunar infarct, that this is a microinfarction that is small, is usually less than 1 centimeter in diameter, and involve the occlusion of the small perforating arteries. Causes are exactly the same: atrial fibrillation, vascular, or any type of hypercoagulopathy. So basically, the difference is based on the history examination and neuroimaging that not always is reliable. So tests to identify common or treatable causes and risk factors for all of this type of stroke are routinely done. Hemorrhagic stroke is most of the time spontaneous, an intracranial hemorrhage that is preceded by hypertension. Is a bleeding from a blood vessel in the brain parenchyma when it's intracerebral. Typical symptoms include also neurological deficit, often with a broad onset of headache, nausea, and impairment of consciousness. The etiology is exactly the same as before explained. In addition, a patient also has a risk of bleeding when they have a congenital aneurysm, arteriovenous, or any other vascular malformation, trauma to the brain, brain infarcts that are large enough to produce a hemorrhagic conversion, patients that have brain tumor, any excessive anticoagulation, blood dyscrasia, um, if the patient have, again, any bleeding from vasculitis. So we're going to talk about AVMs and aneurysms in a second. And the treatment is basically control the blood pressure, control seizures episode, and also concentrate on the edema. So, anticoagulants and antiplatelets are contraindicated when the patients have a bleeding episode. If the patient uses anticoagulation, for example, for AFib, and if it's Coumadin, for example, and the INR is elevated, you could reverse that with vitamin K or fresh frozen plasma. If it's related to thrombocytopenia, you could transfuse platelets, um, and again, control hypertension and seizures. Now, intracranial aneurysm is no more than a weak or bulging area in the arterial vessel. Most are located at the bifurcation of the circle of Willis. There are different types: saccular, fusiforms, mycotics, or traumatic. These are the examples, representation of the aneurysms. Frequently, patients are asymptomatic, um, but when the patients do produce symptoms, most likely are related to cranial nerve 3, 4, 5, and 6, which, again, if you recall, those are related to oculomotor uh, and also trigeminal. So, a question is: a nurse recall that fusiform aneurysms um, are mostly congenital or common in children, or they're due to arteriosclerotic changes or from an arteritis caused by bacterial emboli. So going back again to the aneurysms, again, it could be mycotics caused by bacterial emboli. In addition, other vascular malformations that are rare and most likely are congenital. Uh, Different types are cavernous, um, capillary telangiectasias, venous angiomas, or AVM malformations. So this is no more than an artery feeding directly into the vein, and you should imagine that the arteries have a very high pressure, and the veins are very distensible. When high pressure goes into a low pressure system, which is the vein, increases the um, damage at the level of the wall, creating an aneurysm as well, or rupture. So patients sometimes the main complaint will be headache. Sometimes they're misdiagnosed with migraine. Patients when they have bleeding, of course, is irritation of the meninges provoking seizures, um, or patients could also suffer from subdural hemorrhage. So now let's talk about subdural hemorrhage or subarachnoid hemorrhage, which is another type of bleeding. So subarachnoid hemorrhage is no more than a sudden bleeding into the subarachnoid space. The most common cause is a rupture of an aneurysm, and these patients include symptoms of sudden severe headache, the worst headache of my life, um, usually with loss or impairment of consciousness. Patients also could have secondary vasospasm that causes focal brain ischemia, meningism, and even hydrocephalus and up to obtundation. Um, Subarachnoid hemorrhage is bleeding between the arachnoid and pia mater. Generally, causes is caused by head trauma. Um, but traumatic subarachnoid hemorrhage is usually considered a separate disorder. Uh, Patients could also have intracranial saccular or berry aneurysm that could provoke this bleed. Symptoms, again, headache is usually severe, peaking within seconds, so patients could have loss of consciousness, usually immediately, but sometimes not for several hours. Patients would have severe neurological deficit um, and become irreversible within minutes. Sensorium is impaired or consciousness, or on the other counterpart, patients could be restless, seizures are possibly present. Usually, the neck is not stiff compared to meningitis, unless there's a cerebellar herniation. However, within 24 hours, chemical meningitis could occur and patients could have meningisms, vomiting, and also um, alterations in reflexes and respiration as well. Diagnosis is basically by CT, spinal tap to differentiate from meningitis, and the should do also transcranial Doppler to rule out vasospasm that these patients tend to have. Very common, and the treatment is basically the stroke protocol and also avoid vasospasms with nicardipine and nimodipine, which are calcium channel blockers. So control hypertension with calcium channel blockers could be done as well, um, and also surgical intervention for the aneurysms. Mortality is really high. So again, this is the whole pathophysiology. Patients could have leaking vessels with episode of headache, changes in mental status, nausea, vomiting, and changes in speech or stiff neck once there is meningisms. Um, Patients, when the vessels are ruptured, they have a throbbing, explosive headache associated with nausea and vomiting and loss of consciousness. There's also, again, later, meningisms, which is meningeal irritation with neck stiff that usually doesn't happen early. Patients would have Kernick's and Brusinski's sign positive, photophobia, and irritability. Really high mortality within 2 weeks to a month due to vasospasm, so we have to prevent that. Headache, let's go through the pathophysiology and the types of headache. Headache is basically a pain in any part of the head, including the scalp face and interior of the head. Headache is one of the most common causes of patients seeking medical attention. Basically, it's due to activation of pain sensitive structures around the brain, skull, face, and sinuses. Uh, Patients could have primary or secondary type of headache. Let's go through the primary first. We have what's called migraine, then cluster headache, and also tension headache. That's the classification for primary headache. And secondary headache is related to a secondary disease that could produce headache, which could be again stroke. It could be due to glaucoma, sinusitis. It could be due to brain tumors. It could be due to infectious process such as encephalitis or meningitis. It could be due to severe hypertension or hypercapnia or hypoxia or viremia or analgesics overuse. It could also be due to nitrates, proton pump inhibitors, or caffeine withdrawal or cocaine. So basically, the difference between primary and secondary is that the primary um, is related to either migraine clusters or tension, and secondary is related to a disease process. So let's talk about migraine, as usually lasts 4 to 72 hours. Patients could have aura or no aura, which is no more the symptom that precedes the headache episode, and the patient tends to recognize this as the symptoms of onset of the migraine. So it's an episodic primary headache disorder. Pain is often unilateral, but it's throbbing worse with exertion associated with nausea and sensitivity to light, which is photophobia, or sounds phonophobia. Uh, Auras occur in 25% of patients and usually just before, but sometimes also after the headache. So, migraine is thought to be a neurovascular pain syndrome, which it is altered by central neuronal processing. Um, Many potential triggers could be drinking wine, red most of the time, skipping meals, excessive others, weather changes, sleep deprivation, stress, hormonal, such as menstruation. Certain foods can also provoke it. Head trauma, neck pain, TMG, dysfunction, TMJ, which is temporomandibular joint, um, and also could be familial. Patients also with migraine headache tend to have attacks of amaurosis fugax and um, sometimes ataxia and confusion and obtundation that could be very difficult at that time to differentiate from TIA or stroke. Mechanisms could also be associated with trigeminal compression, such as trigeminal neuralgia. Um, versus cluster headache is chronic paroxysmal hemicrania. It's also named like that. Um, Patients would have several attacks during the day and for days with spontaneous remission. Um, is most of the time associated with ptosis, lacrimation, rhinorrhea, nasal congestion. Typically begins at age 20 to 40. Alcohol could trigger these episodes of headache as well. Symptoms are very distinctive from migraine. Uh, Often occurs at the same time each day, often awakening patient from sleep. When attack occurs, pain is always unilateral and occurs always on the same side of the head. Um, Most of the time, retroorbital or temporal. It is excruciating. It peaks within minutes and also subsides spontaneously. Patients are agitated, restless, unlike migraine patients who prefer to lie quietly in a dark room. Patients with cluster headache, that restlessness can be so severe that it leads to a bizarre behavior. Patients sometimes bang the head on the wall, um, and it's also associated with rhinorrhea, facial flushing, and even unilateral pupillary constriction. And you will see the treatment also in pharmacology. This is again the difference between hemicrania and now tension headache that is the most common is actually mild to moderate type of pain without any type of incapacity, nausea, or photophobia. Um, Symptoms, um, unlike migraine, that patients have photophobia and phonophobia, tension type headache are not associated with nausea or vomiting, not associated with physical activity or light or sounds or smells. Potential triggers are sleep disturbances, stress, TMJ, dysfunction as well, neck pain, or stress in your life. But the symptoms most of the times is bilateral headache, is not unilateral. It feels like a tight band or pressure around your head. It could also be acute or chronic. So patient arrives to the clinic and reports unilateral headache for 2 days that worsens with movement and light. No trauma has occurred. The nurse suspects migraine headache. So now let's talk about infectious processes, and here will be meningitis and encephalitis. So it's most commonly caused by bacteria, but it also could be virus, fungus, parasites, or even mycobacteria that it could actually enter the brain by either hematogenous spread from bacterial septicemia or a contiguous infection. For example, patients can have sinusitis or otitis or mastoiditis and develop meningitis or encephalitis by close contact with meninges from the sinuses or the ear. Um, there is the neuronal or glial infection that causes major inflammation and edema and interrupts the cerebrospinal fluid pathway and also the neuronal pathway. Examples that we will discuss: some acute or subacute bacterial meningitis could also be related to epidural brain abscesses, encephalitis, peripheral neuropathies, or neurosyphilis. All will cause no more than an invasion of the CNS tissue with inflammation and neurotoxins being released, producing fever, head or spine pain with neurological dysfunction. So let's talk about meningitis. It's an inflammation of the meninges and the subarachnoid space that may result from infection or other disorders or even reaction to drugs. Severity could vary. Physical findings is basically headache, fever, and nuchal rigidity. There are many types. Patients could have acute bacterial meningitis, viral, which is aseptic, non-infectious, recurrent, subacute, or chronic meningitis. Uh, Acute bacterial meningitis is particularly serious and rapidly progressive. Viral or other non-infectious such as fungal parasites are self-limited. Um, Aseptic meningitis is an older term. It's sometimes used synonymously with viral meningitis. However, it usually refers to acute meningitis caused by anything other than bacteria. Those aseptic meningitis can be a virus, it could be drug related, it could be Lyme disease, it could be treponema. Major symptoms again are headache, fever, and nuchal rigidity. Patients could have throbbing headache that increases in severity. They could have photophobia. They could have Kernick and Brusinski, projectile vomiting. Um, the others could have exactly the same thing, but the symptoms would be milder. Uh, Kernicks, if you recall, is the resistance of passive knee extension. And Brusinski is full or partial flexion of the hip and knees when the neck is also flexed. Versus encephalitis, that would be no more than inflammation of the parenchyma of the brain resulting from direct infection. Um, Acute disseminated encephalomyelitis is when occupies the brain and the spinal cord. Um, Both disorders are caused by virus. Symptoms include fever, headache, altered mental status, seizures, other focal neurological deficits, and the diagnosis is only by CSF analysis, the same as meningitis, and treat the underlying cause. Patients could have delirium, confusion. Now let's talk about Lyme disease. Lyme disease is a tick transmitted infection. It's caused by Spirochete borrelia burgdorferi. Um, Involves peripheral nervous systems and also central nervous systems. Uh, Early symptoms include erythema, which is a migraine rash or erythema migrans, which may be followed weeks to months later by neurological, cardiac, or joint abnormalities. So patients could have generalized malaise, fever, muscle pain, stiff neck, headache, followed by arthritis or any type of radiculopathy. Most commonly present in Connecticut, and now is the most common reported tick-borne illness in the USA. but it could be present in Virginia, Wisconsin, Minnesota, Michigan, California, Oregon. Basically, it's transmitted by the Borrelia burgdorferi uh, on patients that tend to hunt or be camping um, or in the woods. This Borrelia enters the skin at the site of the tick bite, and after 3 to 32 days, the organism migrates locally in the skin around the bite and spreads via lymphatic to cause disseminated um, blood infection and produces an inflammatory reaction called erythema migrans. And that's when there is release of antibodies into the blood and there is serological conversion. There are different stages. Stage 1, which occurs within a month of a bite, and patients would have the erythema migrans, which the appearance is like a target or um, what's called bull's eye rash with flu-like symptoms. That's the first sign of the disease. Occurs in 75% of patients, and then that's a red macule or papule on the side of the tick bite that most of the time appears in the thighs, in the buttocks, or the axilla. Um, if you see it has normally an appearance of a target or a bullseye. Then the second stage would be early disseminated, that basically spreads the bacteria causing malaise, fatigue, chill, fever, headache, stiff neck, myalgias, arthralgias, um, and occupies cardiac and neurological. Patients could have meningitis, encephalitis, Bell's palsy, or they could have first degree AB block or third degree AB block, pericarditis, or cardiomegaly or cardiomyopathies compromising ejection fraction. And the late stage is basically arthritis that develops in about 60% of patients if the disease is not recognized and treated properly. Diagnosis is basically by serological. You would do cultures of the relevant body fluids, which is CSF and joint uh, synovial. You would do an IgG, an IgM. Uh, you would do an ELISA test to be able to recognize the serologic antibodies present in blood. And the treatment is basically amoxicillin, doxycycline, or ceftriaxone based on practice guidelines that we're going to go through in pharmacology. Now let's talk about demineralization disorders, which include multiple sclerosis and Guillain-Barré and Myasthenia Gravis. Um, basically, in multiple sclerosis, what you have is demyelinization in the brain and the spinal cord um, versus peripheral nervous system, that will be Guillain-Barré. The causes are for both genetic infections, most of the time preceded by infectious processes, viral syndrome before, or it could be related to an autoimmune reaction as well, or toxins. So multiple sclerosis again is the disseminated patches of loss of myelin in the brain and the spinal cord. Common symptoms include visual and oculomotor abnormalities. Patients would have paresthesias, weakness, spasticity, urinary dysfunction, and mild cognitive symptoms. Typically, patients would have multiple neurological deficit with remissions and exacerbations. Diagnosis require clinical and MRI evidence of it. So patients would have optic nerve, blurred vision, vision problems, ptosis, uh, or spinal multiple sclerosis that chiefly involves the spinal tract uh, and dorsal column. Patients would have weakness, numbness, bladder and bowel movements. So basically, the symptoms are at every level. Um, they would have relapsing and remitting pattern um, with remissions and exacerbations. They would have paresthesias, weakness, clumsiness of the legs, diplopia, scotomas, ptosis, up to ataxia and weakness. Sometimes they have short attacks. That's basically caused by minor increase in body temperature or by increase of calcium concentration um, provoked by stress. Patients tend to have sensory or motor symptoms, disruption of weakness, damage of the corticospinal tract. Deep tendon reflexes are usually increased. Um, they could have Babinski, they could have clonus, they could have spasticity, um, they could have cerebellar dysfunction as well, including tremor, nystagmus. They could also have sensation loss, burning, electric shock pain, so it's neurological pain, and also they could have anesthesia in the spinal cord. There's no cure for this. Basically, it's corticosteroids, immunotherapy, and disease modifying. Um, you could go through the question. Now let's talk about neuropathies and basically mostly Guillain-Barré. So if we go through Guillain-Barré is no more than peripheral neuropathy that affects the distal axonal, producing demyelinization as well, but at the level of the periphery. Um, it could be acute, it's rapidly progressive, self-limited, uh, characterized by muscle weakness and also mild distal sensory loss. It's actually thought that it's an autoimmune disorder. Um, it's the most common acquired inflammatory neuropathy. The cause is not fully understood. It begins 5 days to 3 weeks after an infectious process most of the time, but also it could be followed by surgery or vaccinations. It could also be associated with Campylobacter jejuni or any other virus in the GI tract, or it could also be related to cytomegalovirus or Epstein-Barr virus. The most common presentation of Guillain-Barré is flastic weakness. That is always the most prominent symptom. Um, the symmetric weakness with paresthesia usually begins in the leg and progresses to the arms, but occasionally begins in the arms and the head as well. 90% of patients would have weakness, maximal weakness in 3 to 4 weeks. That deep tendon reflexes here are not increased, on the contrary, are lost. That's the main difference between multiple sclerosis and Guillain-Barré. Um, Sphincters are usually spared. Patients would have weakness, uh, facial, oropharyngeal muscles are also weak. Patients will go through dehydration, undernutrition, up to the point of respiratory paralysis that they require endotracheal intubation. Uh, Few patients have significant life-threatening autonomic dysfunction with inappropriate ADH secretion going into SIADH or diabetes insipidus. There's another variant that is called Fisher or Miller-Fisher that instead of being an ascending pattern is descending pattern and is associated with ataxia and areflexia. Diagnosis is no more than through CSF analysis or you could do clinical evaluation or electrodiagnostic test. and it would be differentiated among, for example, myasthenia gravis that we'll discuss in a second. So we talked about radiculopathies in sciatic nerve. So let's continue to myasthenia gravis, and that will be the last topic. So myasthenia gravis basically involves episodic muscle weakness and easy fatigability, and is caused by autoantibody and cell-mediated destruction of acetylcholine receptors. It is the most common disease among young women, but may occur in men or women at any age. Symptoms worsen with muscle activity and lessens with rest. Is produced by muscle-specific kinase protein antibody that degrades acetylcholine. Um, Also, another theory is that autoantibody are present against the calcium channel. Um, it could also be congenital. So basically, the main pathophysiology is that IgG antibodies are produced against the acetylcholine receptors in the postsynaptic membrane or space. So these autoantibodies are created and attack and destroy the acetylcholine, causing decreased transmission of the nerve. So here you have a representation of this pathophysiology. And there are different type of classifications that could be neonatal, ocular, generalized, or a severe form that is related to this muscle-specific kinase protein attacking acetylcholine. And the clinical signs and symptoms range from the most common symptoms being ptosis, diplopia, and muscle weakness that affect um, the bulbar muscles. Weakness resolve when the affected muscles are rested, but recur when they are used again. So ocular muscles are affected in 40%, and eventually 85% of patients would have mostly this diplopia and ptosis. Hand grip may alternate between weakness and normal. Neck muscles are also weak. Proximal limbs weakness as well. Altered voice, nasal regurgitation, shocking, dysphagia. Um, Deep tendon reflexes tend to be normal though. So they have exertional fatigue and weakness that improves with rest. That's the hallmark. Weakness and fatigue of muscles of the eyes with diplopia, ptosis, difficulty swallowing with shocking episodes. Now, something important that you have to remember is the difference between myasthenia crisis and cholinergic crisis. Myasthenia crisis is no more than a severe generalized quadriparesis, meaning all the limbs are weak. This is a life-threatening disorder because respiratory muscles also weaken and patients can go into respiratory failure. So it's a severe muscle weakness leading to respiratory distress versus cholinergic crisis that is muscle weakness that can result when the dose of neostigmine or the anticholinesterase drug that is given to the patient is the level is too high, and a mild crisis may be difficult to differentiate from worsening myasthenia. So basically, the difference between 1 and 2 is that cholinergic crisis is when you overdose the patient with the medication, and the patients also would have more or less the same symptoms, but associated with increased lacrimation and salivation, tachycardia, and diarrhea, because those are the symptoms of muscarinic overdose. Um, and the treatment is no more than, since this disorder is associated with decrease or lack of acetylcholine, you're going to block the acetylcholinesterase, that's the enzyme that degrades the acetylcholine, so you would have more acetylcholine in the postsynapses, and you have Rituxan, These patients will also be immunocompromised, so they have a higher degree level of infection. Okay. For myasthenia gravis, you basically give plasmapheresis versus in cholinergic crisis, since this is an overdose of drug, you will hold you will hold the drug to avoid toxicity. That will be the end of this presentation.